So there are a lot of similarities between Rucaparib and Olaparib, but some very important differences. So both drugs inhibit PARP 1, 2, and 3, but Rucaparib is felt to have some increased inhibition as compared to Olaparib. Also, Rucaparib inhibits tankerase 1 and 2, which is unique. Both drugs have very similar half-lives, which means that both are dosed twice a day. There is a very similar volume of distribution for both drugs, around 100 to 200. And protein binding is also anywhere from 70 to 80%. Now, while both drugs are metabolized by the cytochrome P450 system, they're metabolized by different pathways. So Rucaparib is metabolized by the CYP2D6 enzyme, and Olaparib by CYP3A4 and 3A5. And that's an important distinction because Olaparib needs to be dose adjusted if a patient is taking another drug that either induces, or inhibits the CYP3A4 or 5 enzyme. Also, Olaparib needs to be dose adjusted in renal impairment. Some of these differences are important because they affect the safety profile of the drug. So Olaparib, it's not uncommon to see an increase or an elevation in creatinine. That was seen in about 44% of patients on trial. Rucaparib, you tend to see a greater increase in creatinine, around 92% of patients, and you also see a significant increase in ALT and AST in about 75% of patients. In both of these instances, these findings tend to not be clinically significant. You can treat through a lot of these lab abnormalities, and they will eventually normalize with prolonged treatment.
The ARIEL 2 trial investigated the value and efficacy of the PARP inhibitor Rucaparib in patients that have platinum-sensitive ovarian cancer. The study had an intelligent design since it did analyze the tumor tissue for defects in homologous recombination repair. In this study, this was done by what's called loss of heterozygosity, which is a hallmark of homologous recombination deficiency. BRCA1 and BRCA2 genes proteins are very much involved in homologous recombination repair, and once mutated, that repair is deficient. There are a lot of other genes that do play a role in this very important pathway. The Rucaparib study did identify a group of patients that had not BRCA1 and 2 mutations, but otherwise significant changes and deficiency in homologous recombination repair. What was found in this study is that those patients that had BRCA1 and 2 mutation indeed had a significant better response to Rucaparib and an increased progression-free survival compared to those patients that did not have a BRCA1 and 2 mutations. In addition, those patients that had high degrees of deficiency in homologous recombination repair likewise had a significantly increase in progression-free survival compared to those patients where homologous recombination deficiency was low without any BRCA1 and 2 mutations. I've used Rucaparib in my patients in my personal practice occasionally. Rucaparib was approved just very recently. I personally have seen that patients are very interested and excited about receiving a drug like Rucaparib that provides, based on the study, a meaningful increase in progression-free survival. Patients do appreciate the idea that we can, with a drug that's well tolerated, increase the time to when they need the second treatment. The Rucaparib approval is based on the presence of germline mutations or somatic mutations. We do find that about 15% of patients have germline mutation in BRCA1 and BRCA2, but there's at least about 10% of patients that have somatic mutations in their tumor, for which Rucaparib is likewise a very meaningful drug.
The ARIEL 3 trial was a large, multi-center, randomized, phase 3, placebo-controlled trial That was a 2-to-1 randomization of 600 milligrams twice daily of Rucaparib versus placebo. These patients were enrolled in 3 nested cohorts, a germline BRCA cohort, a homologous recombination deficiency cohort, and then what they call the intent to treat cohort. The results of the trial for the germline BRCA mutated patients showed a difference in progression-free survival of 15.4 months versus 5.4 months. This represented a hazard ratio of 0.24, which was really quite exciting, seeing these big differences in the 2 groups. When we look at the homologous recombination defect group, we see that it was around 16 months versus 5.4 months. Again, highly statistically significant with a good hazard ratio. In the intent to treat population, we're looking more like 9 versus 5.4 months, but still highly statistically significant in that cohort. So quite exciting results from this trial. It really allowed all comers to be evaluated regardless of BRCA status and still showing benefit of treatment with Rucaparib over placebo.
So although PARP inhibitors have demonstrated increased activity in both the treatment and maintenance setting, we don't have a whole lot of data in terms of PARP inhibitors as compared to standard of care chemotherapy. So ARIEL 4 is a phase 3 randomized controlled trial evaluating Rucaparib versus standard of care chemotherapy in patients with recurrent disease who have a BRCA 1 or 2 mutation and have had greater than or equal to 2 lines of prior chemotherapy. This trial is currently enrolling.